this section, I'm going to be talking about extracellular fluid deficits and excess. Okay, and I'm going to look at the clinical manifestations of each, and the nursing diagnosis, and then the nursing implementation of each one of these particular types of disorders. Now, recognize that with extracellular volume deficit, this occurs when we have patients maybe that have diarrhea, vomiting, hemorrhage, polyuria, which means excessive urinary output, inadequate fluid intake, and then sometimes you'll see where physicians will interchange this, and even myself, with dehydration. And then when you read in your book, it talks about dehydration being pure fluid loss. But I don't know of too many people that actually would just lose just fluid without losing electrolytes and things like that. But I guess maybe at some point it might occur. So the clinical manifestations of extracellular fluid deficit are going to be restlessness, drowsiness, lethargy, and confusion. Now, the thing you're going to find with this is you can find a lot of this stuff, these similar symptoms, with other disease processes. But just recognize when you start to work with patients and you see somebody that's restless and drowsy, lethargic, start doing that assessment and trying to figure out, is it an electrolyte imbalance? Is it an oxygen imbalance? What's going on with this patient? Okay. Also, we will see patients that have thirst or dry mucous membranes, and remember, with the older adults, sometimes this effect could be blunted, and we'll actually see almost kind of ridges on their tongue, almost furrows, like deep craters. Individuals that have excess fluid volume deficits may have cold, clammy skin, and when I think of this, I think of if you don't have enough fluid, they're not going to have good perfusion, right? And so when you don't have good blood perfusing through, good amount of fluid and fluids perfusing through the body, the skin's going to get cold and clammy. We may see decreased skin turgor and a decreased capillary refill. Postural hypotension, which means when they go to stand up. Okay, sometimes you'll see orders for us to be checking for orthostatic hypotension. But if a patient maybe just had surgery and had some blood loss, and the first time you go to stand them up and they get dizzy and almost sick to their stomach and get diaphoretic, they could be experiencing postural hypotension. We'll see an increased pulse because our heart is trying to compensate. We don't have that fluid volume, so our heart's having to pump faster in order to get the fluid we do have to where it needs to go. And we'll see decreased CVP, cardiovascular pressures. Decreased urinary output, and your urine will be concentrated. So when we're looking at output on urine, we're looking at 30 milliliters or less an hour. We do not want to see that, okay? And you'll see the urine begin to get much darker and more concentrated. We'll have an increased respiratory rate because, again, our body's trying to compensate. Weakness and dizziness, we may see that weight loss with that fluid loss. Remember that 2.2 pounds equals 1,000 milliliters. And as fluid and deficit becomes more extensive, we could see seizure and coma because we're probably also going to have some electrolyte abnormalities as well. Extracellular fluid excess clinical manifestations, headache, confusion, lethargy. Are we seeing some similarities? You're going to see some similarities between the two. The important thing when you're studying is to figure out what's different in regards to the signs and symptoms. Peripheral edema, meaning edema in the hands, the feet. You may see it if they're laying in the bed. You'll see it on the sacral area. You may see it in the stomach. It just depends. Jugular vein distension, which is along your neck here. You'll see a pounding pulse. S3 heart sounds. You'll see a lub-dub is your normal heart sounds. You'll have an extra S3 in there. Bounding pulses. I think I said this before. Bounding pulses. We've got a lot of fluid. The heart, again, is trying to compensate for the excess fluid, so it's going to be pushing those pulses, or pumping that blood, as fast as it can, and we're going to have those bounding pulses. Increased blood pressure and increased CVP. Polyuria. Now, excess or amount of urine output, it means poly. With normal renal function, you may have polyuria. When we get into patients that don't have normal renal function, though, then we run into problems. They may not be able to have the output that they need, so then we're going to end up with dyspnea and crackles and pulmonary edema because they have poor kidney function. They can't get rid of the fluid in a normal fashion. Muscle spasms may also occur. And we may also see weight gain, and again, seizures and coma is something that could eventually manifest itself with these patients. The nursing diagnoses for excess fluid volume deficit. All right, when you're thinking about these, deficient fluid volume, Okay, related to extracellular fluid losses or decreased fluid intake. So we could have it from a loss, or we could have it because we're nauseated and we just cannot take in any fluid. Deficient cardiac output, okay, related to related to excess fluid volume losses and fluid intake. And decreased cardiac output depending on the person's heart and how well it's working, okay. Risk for impaired oral mucous membranes, related to fluid volume deficit, and then potential for complications. Hypovolemic shock means total shock. Okay, eventually if you don't have enough fluid, what fluid and blood and things that you do have are going to try to go towards the vital organs. So we're going to have lots of symptomatology with shock, which I'm not going to get into in this section. Extracellular fluid volume excess, nursing diagnosis. So we can have excess fluid volume related to increased water or sodium retention. Meaning that the sodium, remember, water follows sodium. So if you've got a lot of salt, you're not going to excrete that urine very easily. Impaired gas exchange related to water retention, secondary to pulmonary edema. So when we get fluid in our lungs, we're not going to be able to exchange oxygen and CO2 adequately. So then we're going to run into problems with our patients, with how they're breathing and their oxygenation. Risk for impaired skin integrity. This is in relation to edema. When somebody has edema, then they're at higher risk for skin breakdown because that fluid sits in the tissues, and you just bump them sometimes and their skin will break down. Activity intolerance related to increased water retention and weakness and fatigue. And then disturbed body image can be related to the edema in the way that somebody looks. Sometimes they'll have facial edema and things like that. And then we can see potential complications such as pulmonary edema and ascites. Ascites is where you get the fluid around the stomach. Remember, if the fluid has nowhere else to go, it will create third spacing. So it goes into another cavity, and the only way to get it out is to do paracentesis and thoracentesis on patients. Okay, depending on thoracentesis means fluids in the lung, para is in the stomach. So our nursing implementation for these patients is to do daily weights. And again, I think I've said this 3 or 4 times, so if y'all miss it on a test, the increase 2.2 pounds equals 1,000 milliliters of fluid retention. We're going to want to check, a lot of times the fluid deficit takes into account, we need to figure out what is the underlying cause. Is it because of nausea, vomiting, diarrhea? Is it because they have renal function impairment? What is causing them to have this fluid and electrolyte imbalance? Intake and output, we need to keep in mind what oral, IV, feeding tubes, things like that. Anything we're using for irrigants needs to be taken into the intake. Anything that's coming out could be NG tube, could be diarrhea, urine output. They tell you in your book to try to estimate the insensible losses. That's kind of difficult to do. We just need to keep those things in mind. If they're sweating a lot, that might be something that we want to note. Laboratory findings I'm going to go through on the next page and kind of touch on. I have a chart that you're going to want to know what those laboratory findings mean. Cardiovascular care, when we're looking at nursing implementation, remember what I said. Vital signs can play into your assessment if you have low blood pressure versus high blood pressure, low pulse versus high pulse, temperature. Patients that have lost a lot of fluid sometimes will run a low-grade fever. So we want to keep an eye on our vital signs and our cardiovascular assessment, listening to our heart sounds, jugular vein distension, how do our pulses feel, what is our capillary refill, things like that. Respiratory care, assessing our pulse ox, assessing our lungs, listening to see whether we have crackles, what is our respiratory rate, is it within the normal parameters that you've previously learned in your classes. We want to look at skin care, patient safety as well. Patient safety, this has to do with orthostatic hypotension. Also, these patients, when they have fluid and electrolyte imbalances, remember what we said, they'll get lethargic, they'll get confused, depending on what's going on. Some of them maybe get combative, so safety becomes a very large issue. With skin care, we want to make sure we're assessing the skin, turning patients every couple of hours. If they're dehydrated and their skin is dry, we might want to use some lotion on those areas. And then fluid therapy, you're going to see as we get into a little bit more into another section, I'll talk in more depth about fluid therapy. But if it's mild, we're going to do oral hydration. If it's severe, we may need to replace that volume. So they may use blood products such as normal saline 0.9% normal saline or lactated ringers. If the fluids loss is because of blood or hemorrhage, then they may give blood products as well. If we have excessive or excess fluid volume, then they're also going to treat the underlying cause, and they're going to try to remove the fluid. So if we've got that patient that has, I don't know, drank 2 gallons of fluid or something like that of water, or they accidentally opened up their IV pump and everything flowed in, and now they're in fluid volume overload. They're going to figure out the underlying cause. They may use diuretics or put patients on sodium restrictions as well. This next page, I want to show you the lab values, and I'm giving you this, and this is something you probably need to copy and go ahead and put somewhere so that you have these lab values. Yes, you need to know these. You need to recognize that with the serum osmolality, if it increases, it's going to increase with dehydration, and it's going to decrease with water excess. Blood urea nitrogen, or BUN, this is our typical normal value. It increases with decreased renal blood and decreased urine production, so causing reduced urea clearance. Dehydration, so a lot of times you're going to see this. If someone's dehydrated, you will see that BUN go up. Whenever it's a renal issue, you'll see the BUN and creatinine go up together in a ratio proportion manner. Hematocrit. This is important when we're looking at our CBCs. Hematocrit in female, in male and female, there's your values right there. It increases in fluid volume deficit, okay? It increases because, again, we don't have that fluid, so our blood is going to be more concentrated, okay? Creatinine elevated when 50% or more of the nephrons are destroyed. I already talked about that in relation to the BUN. Serum glucose is markedly elevated in bloodstream when you have somebody that has osmotic diuresis and fluid volume deficit. You're going to learn more about that when you talk about diabetes complications next semester in your 3rd semester. Urine osmolality reflects changes in the urine contents. Okay, so you need to kind of keep an eye on this. When osmolality is concentrated, when urine has an osmolality of 1,000. Urine-specific gravity is one that we're going to look a little bit more intently at. So it increases with any condition causing hypoperfusion of the kidneys. So dehydration or shocks, if you see an increase in this, it means it's more concentrated. If you see a decrease, then it means that that person is not able to concentrate the urine as well. Going along to your normal serum electrolyte values, I know that you've had this last semester, so you're going to need to know what these values are. That's something that you're going to have to memorize. And so I'm going to conclude here, and then the next section we'll be talking about is I'll start getting into osmolality imbalances in the next section, and then each section after that I'll talk about different electrolyte imbalances.